Anand. At the outset, I would like to thank Dr. Uni and Dr. Manoj and the entire IRC team. So I'll be trying to cover the significance of HRF in Drusens. So if you look at the pathophysiology, it usually starts with the death of the cells and anti-migration. So basically they're induced by cytokines and inflammatory factors to oxidative stress. That's how these cells kind of migrate anteriorly. So I have one case wherein I'll be covering both the extremes. One I went in for a total outer retinal atrophy, and the other I went in for a CNVM. So this is a 78-year-old gentleman. This was a presentation in Jan 2020 with HRF. You could see some mixed hyperreflectivity sub-RPE, and this was almost the same in March 2020, but suddenly he went in for a outer retinal atrophy, and this went on, but luckily the vision remained stable. Then comes the other eye, wherein we can see a minimal amount of HRF here. But September 2021, there's a new PED that had started with an increase in HRF. And this went on to started developing sub-RP, hyperreflectivity, subretinal fluid, and increase in the fluid content. And he received multiple injections. It's a waxing and waning course. So this is the difference between both eyes in the same patient. So there's another terminology called RPE plume, wherein it's described as cells which cross the retina within the Henry fibril layers. So there's a variety called curvilinear, thread, and coma and vitaliform types. So they had seen the longitudinal progression of these varieties over a period of time. What really happens? You can see the collapse of the PED here, and there's a complete outer retinal atrophy. And this is a curvilinear plume, and again, this also led to an atrophy with some cystic spaces. And this is a coma type plume with which has developed into HRF with the PED collapse again. The D and E variety, again, there is a change in the type of plumes over a period of time. So HRFs in dry, intermediate AMD and MNVs, you can basically see this is how it looks like in ONL, but when you look at in a CNVM case, there are multiple HRFs and MNV, and even they migrate anteriorly. You could see the lipid globule, which is hyperreflective. It does even have a hypertransmission tail. This is a macular study, macrostar study, which has studied the structural features in AMD. You can see that HRFs are almost equal to, it's almost equal like a surrogate of a pigmentary change on CFP. And when you look at the intermediate AMD and the changes in HRF, the distribution, the Drusen distribution exactly foveal, whereas if you look at HRF distribution, it is juxtafoveal. It is a little more temporally and a little more juxtafoveal. And when you look at visual acuity changes, there is this study wherein they looked at low luminance visual acuity, microperimetry, contrast sensitivity, that found that eyes with HRF, and when they compared with eyes without HRF, there was more diffuse and advanced form of AMD. There was localized damage and dysfunction of cone cells, worse visual acuity, and worse myopic threshold, Maya threshold. So these are all the studies wherein we had seen qualitative assessment. When you look at the quantitative measurements of this area, we can have a better prediction and progression to late AMD. So there was no significant correlation for CNVM progression alone, but there was significant correlation to complete outer retinal atrophy. If you look at the changes that happen over a period of time till the time of 1 year. So you can see the changes here in HRF, which led to complete outer retinal atrophy, whereas here minimal HRF, and you can see a development of a neovascular membrane. Then again, this study wherein you can use it as a biomarker. You can see the Drusens present more at the foveal area, whereas HRF are more at the juxtafoveal. You can see the progression to MNV as well as progression to macular atrophy. And if you look at the graphs here, as the time goes by, as the HRFs increase, there's a more risk of atrophy. When you compare with the drusenoid volume, there's more risk of neovascular membrane formation. This is again another study which shows the point-to-point changes in visual acuity when they kind of superimpose these CFP images with Maya. And here also they found that the Drusen volume was significantly associated with reduced retinal sensitivity. Even HRF volume also was associated with significant reduced retinal sensitivity. So to conclude, HRFs in Drusens, they definitely have a predictive and prognostic role. They are associated with disease severity. The numbers increase in number and density as time goes by, and kind of migrate into the inner retinal layers. RP atrophy has been noted even in adults to study. And macular atrophy is more seen in these HRFs when they are co-localizing with Drusens, not exactly at the foveal area, but little eccentrically. There are changes in HRF that lead to Drusenoid PED collapse. This is also accompanied by changes in the hyperreflectivity in sub-RPE spaces. This could be even the precursors for type 3 lesions, especially if they are located in the closer to the outer retinal layers. They do have a predictive value in MNV conversion when accompanied with, when there is especially an increase in the drusen volume growth. And it could be definitely a structural endpoint in clinical trials that aim to look at the progression from intermediate AM to advanced AMD. And there is definitely decreased retinal sensitivity in such conditions. Thank you so much for the opportunity.
Thank you very much. So I think this is indeed a difficult topic, but if you can go back to your last slide, what I would like to just highlight is that the HRF, I think we need to understand, when you have these HRF above a PED, like the first case that you showed, they could actually be precursors of neovascular lesions. They could indicate development of retinal neovascularization, and that truly needs to be differentiated from the HRF that lead to atrophy. The morphological appearance of the two is different. They are present in different circumstances, and the OCT appearance of those patients are completely different. So I think this is an important point where you have two types. One is precursor of neovascularization and the other is precursor of atrophy. I think the results of the MACU-STAR study, which you said, are really important because almost 50% patients could have these HRF. And another thing that you must rule out is the vitelliform lesions, which could be there in almost 4 to 25% patients with neovascular AMD, especially those with cuticular drusen. So I think this is confusing enough. Dr. Ritesh, please.
Yeah, just elaborating on the point that you said. So those HRF lesions are more smaller and discrete compared to those precursor lesions which are more round-bodied, little larger in size, and an octa slab running through those lesions will show a flow. That is how you can differentiate. While a HRF would not have that flow, you can differentiate a precursor from a HRF.
Yeah, I think they're plain, early stages of neovascularization.
Are these HRS? I mean, are these HRS what you see, the lipoprotein accumulations?
We don't know if they're really lipoprotein accumulations. It's difficult to answer because I don't think we have studies on that front. But since you're yourself saying that they're precursors of type 3 lesions,
correct,
we can presume that these are precursors of neovascularization. They're neovascular tissue and not really completely avascular lipoprotein deposits. Any other comments from the panel?
That was a very nice talk. I just have a comment about this predictive value in MNV conversion when accompanied by drusen volume growth. We sometimes see before the drusenoid PED collapses, you see the drusen slightly going up and then flattening down, and we've seen that in some of our cases. So I think that may not always be true. Yeah. It may be a precursor to collapse, suddenly growing and then collapsing.
Yeah.
Okay, thank you so much.